Hi everyone, my name is Simrat. I'm an advanced cardiac imaging fellow at Cleveland Clinic and I'll be presenting an interesting mitral valve structural case. This is a 67-year-old female. She was seen in our structural valve clinic for a second opinion from outside hospital regarding long-standing mitral regurgitation for which she had multiple heart failure admissions at her old institution. And she has a significant past medical history. She has a history of congenital bicuspid aortic valve, and she underwent aortic valve repair when she was 14 years old, and then she had a St. Jude's bileaflet mechanical aortic valve replacement at age 48, and then had an ascending aorta replacement because she also had a aortopathy and a biprosthetic aortic valve replacement at age 67 with a 23 millimeter Edwards Intuity elite valve. She has other risk factors with a history of atrial fibrillation and complete heart block post her most recent surgery requiring a dual chamber pacemaker. So she was being followed at outside hospital for a long time, for a long history of mitral regurgitation, where she was turned down for transcatheter therapies. She's already had 3 surgeries before, so this was going to be a 4th redo surgery. So she comes to our hospital for a second opinion. This is her TTE, and I want to bring your attention to that the patient has significant mitral regurgitation. Her blood pressure is 139/65, and you can see particularly in the parasternal long axis view that there seems to be 2 jets of mitral regurgitation. One seems like a functional jet, and the other jet coming close to the aortic anterior mitral valve leaflet, close to the replaced aortic valve. So to understand the mechanism better, this patient undergoes TEE. And you can see really well on the image on the left that the patient has 2 jets of mitral regurgitation. One seems like a perforation just next to the biprosthetic aortic valve, and the other is a functional mitral regurgitation jet, which is due to dilation of the LV due to long-standing MR. And we use multiplanar reconstruction to focus on this jet of anterior mitral valve perforation, which you can see on the top image on the top right, and which is functional mitral regurgitation, and you can see on the image on the top, on the bottom right, that the patient also has functional mitral regurgitation. So we use the glass view this view particularly, and this is the glass view for bicommissural view, and this particularly helps us to determine the 2 PISA jets, which is, and you can see that the patient has one jet that's going posteriorly, which is due to the functional mitral regurgitation, and another jet that's going anteriorly, which is due to perforation of the anterior mitral valve leaflet, and which can also be seen on the more en-face view for the mitral valve. So after discussion with our structural heart colleagues, we decide to take her to the OR for fixing this anterior leaflet perforation as well as the functional mitral regurgitation. And here we do the entire procedure under 3D, and here we're trying to get a transeptal puncture. And as Dr. Kapadia mentioned before, we try to go superior. So this is the mitral valve and this is the aortic valve. We try to go superior to get more height to reach the mitral valve, and a little bit posterior so we are not aorta hugging, and this is where we did the transeptal puncture. We focused our attention initially to the perforation of the anterior mitral valve leaflet, and we guided the interventionalist, and in this case it was Dr. Krishnaswamy, to the perforation where we in the anterior mitral valve leaflet, and he was able to put his catheter into the perforation, and you can see that there's color over there. And this perforation then was successfully closed with an Amplatzer plug. And you can see that at the end of the deployment of the Amplatzer plug, there was no mitral regurgitation coming from the perforation. We got a really, really small box to be able to focus on that perforation and to guide the structural intervention. Then we went on, and again an on-first view, to look at the remaining functional mitral regurgitation, and we see that there is still some degree of functional mitral regurgitation, so we proceeded to intervene on that with the mitral clip. And we got, as Dr. Miyasaka and Dr. Harb showed yesterday, we guide the entire procedure under multiplanar reconstruction with 3D, and we are in this case it was the mitral clip, and we are guiding the mitral clip into the right position between the A2, P2, where majority of the PISA was coming from. And here we're making sure that the orientation and the position is right, as well as both the anterior and the posterior leaflet are in between the two grippers of the mitral clip. This is how it looks on 3D. Once the mitral valve, we go ahead and deploy the mitral valve, and once it's deployed, you can see that the patient has minimal residual mitral regurgitation and had an excellent outcome.
Thanks very much.
So great case and great imaging. Just out of curiosity, I mean, she'd had a lot of aortic interventions over her lifetime. At the most recent, had there been any issue with her mitral valve at that time?
Not that it was reported to us, no. Okay. But after her aortic valve surgery, she had some trivial to 1+ MR, and that just continued to keep progressing.
So part of the reason I ask it, it doesn't happen often that people just spontaneously perforate leaflets, and you're not giving us a history that makes us think, for example, that she had endocarditis. Do you think there's any chance?
I don't think that was spontaneous, though. I don't think that was spontaneous. That's probably
so do you think it might have been iatrogenic at the time of one of her aortic procedures? Is that maybe what happened?
And that's what our guess was too, because the valve itself didn't look, it was damaged by endocarditis or other infections, so we thought that it happened during her previous surgery.
Fair enough. So to those on the panel, Steve.
I just wanted to comment. It's a beautiful case and a very nice result. We've had several similar plugging anterior leaflet perfs, one combined with the mitral clip just like that, and we did it just the order the other way around. The clip first, and that actually stabilizes the anterior leaflet and makes the plugging a little easier.
Yeah, and that's actually a really good point, because we thought about that during the procedure, and I don't think there's a right answer to this. Our thought process was that if we plug the hole first, then there won't be a risk of tearing the perforation when we are cinching the mitral valve with the clip. But I don't really think that there is a benefit of one way or the other.
It's an unusual case. If I had to do it, I would probably plug it first, because once I put a clip there, I'm very careful not to touch the clip and not manipulating close to the clip. I mean, I'm just concerned about that. And I'm poking, because to get to you have to poke many times with a wire to be able to cross. I mean, the rate limiting step to plug a hole is just to cross it with a wire, and then you have to force a catheter through it so you can advance the device and then bring it back. And sometimes it takes stiff wire. Sometimes you have to pull the catheter back, and then you have to try something, and then you have to improvise along the procedure. And having a clip there would really make me very, very nervous.
Just so you know, I mean, this is not like a PVL. It's very easy. The hole is flat, planar, right in front of you.
Yeah.
It's not serpiginous. You're not challenged to get a wire across. It falls across. I mean, It's actually very easy, because it's not like a PVL.
Well, I mean, I'm taking from this as a non-interventionalist that there's more than one way to do this successfully in the right hands, and I will add to that with ideal imaging.